Hello, I'm Dr. Bridget Nash, and I'd like to welcome you to The Therapy Show, a podcast series that seeks to demystify mental health treatment. Today, I'm honored to welcome Dr. Ingmar Gorman, who is a psychologist who specializes in assisting populations who have a relationship with psychedelics, and the co-founder of Fluence, which provides professional education to licensed clinicians in psychedelic-assisted psychotherapy and integration. He is the site co-principal investigator and clinician on a MAPS-3 clinical trial studying MDMA-assisted psychotherapy for post-traumatic stress disorder. Dr. Gorman, welcome to The Therapy Show.
Thank you so much for having me here.
Can you start by telling us a little bit about your personal background and professional development that led to your research into the use of psychedelics to treat PTSD?
Sure. So I'm a clinical psychologist by training, and I actually started this journey by dropping out of the University of Chicago back in 2004. I was studying philosophy there, and it didn't really work out for me. And so I moved back to my home at the time, which was Prague. What I discovered while I was there, sort of on my leave of absence, if you will, was this discovery of this really rich history of psychedelic research that took place in the former Czechoslovakia. And so from that point onward, I was interested in looking at the potential for psychedelic-assisted psychotherapy. And that sort of was the goal that I set, and I pursued it, returned to college, then went to graduate school, and have been really fortunate to receive training at some of the best institutions in New York City, like Columbia University, Bellevue Hospital, the New School for Social Research. And in terms of why, well, I guess I saw psychedelics and sort of related compounds as something that was overlooked in the possible toolkit for psychotherapists. I really wanted to understand, were they fairly abandoned in the 70s, or was there more to potential for these compounds to help people? And that's sort of the question that I've been pursuing really my whole career.
So when and how did you realize that psychedelics, in particular MDMA-assisted psychotherapy, would be an effective form of treatment for PTSD?
I thought it might be good to maybe clarify a few things to begin. So the listeners who are perhaps really informed about psychedelics, they might, I don't want to say turn up their nose, but they might sort of make a correction here that they might say that MDMA is not a psychedelic. And I just think for our general audience, it might be helpful to clarify what do we mean when we're using these words. So psychedelic, that word was coined by somebody named Humphrey Osmond, and it's Greek. And it means to manifest the mind manifesting. And his actual quote was in a letter, I believe, and it was something like, to fathom hell or soar angelic, take a pinch of psychedelic. And that little quote kind of talks a little bit about the range of experiences people can have. We'll come back to that. But psychedelic, that label is referring to the subjective psychological experience. And I think that's a really good description of what these compounds can do, including MDMA. But when people use psychedelic, that term in the professional literature, they're often referring to something that is a more strict definition. Sometimes people use the term classical psychedelic or classical hallucinogen, which means a compound that acts primarily pharmacologically through the 5-HT2A receptor. And so those are compounds like psilocybin or DMT, but it doesn't include MDMA. So I just want to kind of at the get-go kind of clarify that. And then another thing before I answer your question that I think is worth clarifying, because people might be thinking like, oh my gosh, you're working with these drugs and people are going to be taking MDMA every day as a medication. And I just really want to clarify in the beginning that that's not the case. The way that we're working with these compounds in the clinical trials is that people are administered, say, MDMA, say 3 times over the course of 4 months. And the drug is administered in the context of an 8-hour psychotherapy session. And they're kind of accompanied with, it varies, but in our trials, 12 non-drug sessions, 12 90-minute sessions that happen about once a week. And we call these preparation sessions. So they're preparing for the MDMA experience, and then integration. So this is not a take-home medication. People are not going to be using MDMA on their own. And what we believe is happening is that we're kind of leveraging both the effect and the synergy of the drug, the MDMA, and the psychotherapy itself. To answer your question about how did I realize the potential here? Well, for me personally, the possible usefulness of these compounds was really observing people and looking at studies that looked at the non-clinical use. So some people might use the term recreational use. And of course, I'm not going to necessarily advocate that people do this, but we know that it's a fact that people use these substances outside of a psychotherapeutic setting. And for some people, not everybody, but there is a portion of people who report that they are having mental health benefits after these experiences. And you don't usually see that with typical drugs of abuse. People aren't really saying, well, I use alcohol and so my life is better. I mean, some might have some, short-term relief, or maybe it's nice to accompany with a meal, or people don't say cocaine has changed my life for the better. In terms of MDMA-assisted psychotherapy specifically, why might that be a good idea or have some potential? Well, first, it's not mine. I didn't come up with it, but my colleagues, Rick Doblin, George Greer, Michael Nenny-Mithofer, Stanislav Grof, and others were using or were familiar with the potential of MDMA to treat trauma before MDMA was Schedule I controlled substance. And so there weren't any clinical trials at that time, but sort of anecdotally, it seemed to be helpful. Another thing that I'd just like to add to this question is that we talked about psychedelics and what that means. There's another lesser used term or label, entactogen or empathogen. And what that label is signifying is an emphasis on the empathic enhancing effects of MDMA. And that empathy can be directed inward. And we see that often disrupted in people who are living with PTSD. There's this deep guilt, moral injury, real difficulty with self-compassion. And we'll talk probably more about this a little bit later on, but there are also these excellent psychophysiological reasons or biological reasons why MDMA-assisted therapy could be good for PTSD. Now, I also want to just clarify that I'm talking about MDMA specifically. We don't have clinical trial evidence looking at the classical psychedelics like psilocybin for PTSD. So right now we're really focusing on MDMA. And one last point here, because I think data is important, and I know you really value that on your podcast, that this is evidence-based. And I just want to share a little bit about that. So right now, we are halfway through something called phase 3 clinical trials, FDA phase 3 clinical trials. This is sort of the last stage of data gathering before the FDA can review this approach to see if it could become a medicine, prescribable treatment. The outcomes of the first half of phase 3 are actually currently under review. And so I can't speak to them. I would really like to, but I can't. But we will have those available really in time now. But there was a publication that came out just last year, which was a pooled data from 6 different phase 2 studies. There were 107 participants. And what was observed was that there was a reduction in PTSD symptoms measured by something called the CAPS, which is short for the Clinicians Administered PTSD Scale. It's sort of the gold standard for measuring PTSD symptoms. What was observed, there was the statisticians out there, an effect size of 1.58, or basically an average of 44-point decrease. So a big decrease. That's a strong finding in people's symptoms after the MDMA treatment. But what's really neat, even after the treatment was finished, there was still a significant, small effect, but a significant effect for people continuing to get better. The symptom reductions continued 1 year after they left the treatment. So they're continuing to get better even after the treatment is over. Another way to talk about this that may be more kind of accessible is that when the treatment is done, about 56% of participants no longer met criteria for PTSD. And when the researchers looked at least 12 months out, that number actually increased to 67% of participants no longer meeting criteria for PTSD.
I read the journal publication. It was really promising. Thank you for that.
Yeah, you're welcome.
I also wanted to ask you, so these are not drugs of abuse, correct?
Well, that's an interesting question. So I prefer the term misuse. So can these drugs be misused? Absolutely. So in other words, can they be used in a way that can hurt a person? Absolutely. Sort of the person who rediscovered MDMA used to say, you can't take the A out of MDMA. A stands for amphetamine, methyldiazomethamphetamine. It is a stimulant, and there are definitely risks associated with that. The classical psychedelics like psilocybin have a lower risk profile, a much lower toxicity level. Again, MDMA is not, I should say this depends on how it's used, of course. And in these trials, we're giving substances only 3 times. And so that risk is mitigated. But I don't want to convey that these are completely harmless substances.
I think that goes to my next question, which is, why is it important that a thorough assessment and medical exam be performed prior to engaging in MDMA-assisted psychotherapy?
This is where it's interesting as a mental health clinician or somebody who doesn't have a medical degree, because when we do this work, we are in a little bit of 2 worlds, because the drug would be a medical intervention and psychotherapy is obviously a psychotherapeutic intervention. My co-PI is Casey Paleos. He's a psychiatrist. What's interesting is that this field is going to require a lot of collaboration between medical providers and mental health providers. I don't want to speak out of my scope of practice because I'm not a doctor, but I will say one thing, which is that, again, MDMA is a stimulant. And so if a person has a heart condition, particularly uncontrolled hypertension, there can be this cardiac risk. And so it's important that a person who has that vulnerability is screened and make sure that their hypertension is under control. So that's one physiological thing to be aware of. In terms of other possible, maybe more psychological, biological risks, we're currently lacking evidence in clinical trials about how MDMA might affect people living with psychotic spectrum disorders or a family history of psychosis or people living with bipolar disorder. But despite that evidence, generally our wisdom, our experience is telling us that MDMA might exacerbate psychosis or bipolar disorder for those people who are vulnerable. So we're extra careful. I'm hoping that we'll be able to learn more as we do more research, but that's something that I would be very careful about.
Can you describe how PTSD affects the working of the brain and how psychedelics improve the activity and connections in the brain that were affected by the traumatic experience?
Sure. And again, I just want to emphasize that although we could talk about MDMA as a psychedelic, the way that the classic psychedelics and MDMA affect the brain is slightly different. So I'm going to focus particularly on MDMA for PTSD. Well, one thing that we know in PTSD is that what we tend to see is increased amygdala activity, which is associated with an increased fear response, decreased hippocampal activity. This is where memory and emotion is consolidated. And then also decreased ventral medial prefrontal cortex activity. This might be linked to higher top-down kind of emotion regulation, directing, attention, other kinds of cognitive deficits that may be particularly challenging when a person is in a state of being hyper aroused. So activated by, say, a trauma trigger. Now, what's really interesting is that with MDMA in volunteers who are going through brain scans, we see the exact opposite. So there's reduction in amygdala activity, increase in hippocampal activity, and activation in the ventral medial prefrontal cortex. So it's sort of like, you can think on a biological level, there's maybe perhaps this kind of undoing or return to perhaps normal for people who are living with PTSD. But I think it's really important that we also not have just a purely biological reductionist perspective, because it's easy to take that because we're talking about a pharmacological agent. I think it's really important that we kind of take a deep account of some of the psychological mechanisms which are, of course, are also biological, but I think the psychological pieces, we should also highlight those. And to think about this, we administer MDMA only 3 times over the course of 4 months, yet we see these persisting effects. As I mentioned earlier, even 12 months and actually beyond 12 months, people are benefiting. And so one possible hypothesis around this, afterwards and acute, so maybe the psychotherapy elements might be moderators of the efficacy. So they may be modulating how useful the MDMA is. And this is an unanswered question, but this is something I'm really interested in. And my gut tells me that, the psychological variables in people's getting better is an important element, that it's not just the drug alone. Because we also see lots of people take the counterpoint to my previous comment is that we see plenty of people using what they believe to be MDMA in non-clinical settings, but we don't see everybody getting better mental health outcomes. So it's a minority that report that. So it can't be the drug alone. That's my hunch.
PTSD can be debilitating and can affect a person's sense of themselves, their relationships, and their outlook on life. How does MDMA-assisted psychotherapy improve these domains?
That's right. I want to talk about some findings I have and also maybe speculate a little bit. So one thing that we know is that MDMA, aside from the way that affects the brain that I mentioned previously, is that it also is associated with the release of prolactin and oxytocin, which is linked to bonding and trust. And so we also know that PTSD, often there's this interpersonal trauma element, which can make it really difficult to feel safe and trust another person. And so we believe that the reassuring presence of a therapist, along with perhaps the MDMA, allows for a reparative experience for the participant if we're talking about a clinical trial. Another aspect of PTSD that I also mentioned before is this kind of deep sense of guilt or shame and a sense of powerlessness that people have. This kind of makes sense because PTSD is partly a response to being confronted with something that is utterly overpowering and overwhelming. In MDMA-assisted psychotherapy, one of the key components of the treatment, I believe, and something that we implement and teach, is this notion of what we call the inner healing intelligence. Another more common phrase for this might just be like person's intuition. For us, this is really a patient-centered therapy where the therapists are almost like a midwife to the participant's process, rather than trying to be an expert to kind of guide where a person should go. And what I believe that this approach really empowers or reactivates a participant's sense of autonomy and their sense of agency, that they're the ones that are capable of getting better. It kind of localizes the healing in them rather than in the therapists. One more thing I'd like to just add on this question. Last February, I published a paper on something called post-traumatic growth in MDMA-assisted psychotherapy for PTSD. And post-traumatic growth, there's a measure that I used, and the subscales include things like sense of agency, person's interpersonal relationships, their sense of spirituality or outlook at life. This measure looks at whether there are improvements in those domains after a person is engaged in some ways with their trauma. In this case, specifically through MDMA-assisted psychotherapy. And what we saw is that, yes, there was an increase in post-traumatic growth. There was a difference in those who received MDMA-assisted psychotherapy versus those who received the psychotherapy, but with a placebo. And again, there was a strong effect size here, 1.14.
I read that journal publication as well. Very promising. The idea that it can continue, the growth can continue.
Often clinical trials, particularly perhaps ones that are more focused on the pharmaceutical intervention, are looking at the reduction of symptoms. And that's certainly very important. But we tend to often neglect, well, how are people actually living their lives? Like, are their lives better off, or do they have better relationships? Has their perspective changed in some way? And I believe that this data kind of get at that a little bit more.
Do you advise against recreational use of psychedelics?
Having been trained in substance use treatment, my perspective on that is to not try to be in the role of controlling what other people choose to put in their body. And anyone who's had clinical experience treating people with substance misuse kind of know how challenging and sometimes counterproductive it can be, how frustrating it can be to try to control another person's behavior. And that's not what we try to do, of course. But so my kind of stance towards this, and maybe a lot of your audience is going to have maybe strong feelings about me saying that. I'm not sure, but my approach is to really believe that people are trying to make the best decisions for themselves. And my training in integrative harm reduction psychotherapy by doctors Andrew Tatarsky and Gentali kind of really informed me in this way. You can summarize it as sort of a compassionate, pragmatic approach. So we know, say, from the self-medication hypothesis, right, that people are generally maybe using substances in a way to address something that is troubling them. And they can be really effective. Usually, if it's misuse, then usually in the short term, it's effective to say like blunt affect or control a person's dysregulation. But then you have all these negative outcomes associated with that. And so the way that I approach this would be to explore why people are choosing to continue to use, how they feel it's benefiting them, and also explore some of the negative, harmful consequences. And this is sort of very much also in line with MI in many ways, motivational interviewing. And if their choice is to abstain from substances, then that's the goal that we support when they're ready to be there.
And I think that to avoid the rebound effect of sometimes using substances and not achieving the optimal result. I mean, if the goal is to reduce PTSD symptoms and improve outlook, perhaps doing it recreationally, you might not gain all of those benefits.
Mm-hmm. What you're alluding to is the importance. Sort of there's these psychological factors that are really important. That's right. And there are also these risks too that are associated. Say if we just limit it to psychedelics and MDMA. So speaking of those risks, using these compounds outside of a controlled clinical context, I mean, one of the there are a lot of dimensions to this, but probably one of the most straightforward risks is that people don't really know what they're getting if they're getting a substance on the black market. And we know really sadly that sometimes black market compounds or drugs can include adulterants like fentanyl or some novel psychoactive compounds that are psychedelic in nature, but can potentially lead to overdose. So there are other kind of risks. I think that one stands out the most. And for a participant in a clinical trial, say with MDMA, I mean, just the kind of reduction in anxiety and worry that they can trust that this is what we call a GMP grade, so good manufacturing practice grade MDMA, that there are no adulterants and that it's pure. I do believe that dramatically affects just the psychological experience of being able to let go and have the experience. So just like that quote by Humphrey Osmond, psychedelic experiences can be really profound, sometimes blissful, transcendental, but they can also be really scary, really disorienting, unpredictable, even to use his words, potentially even kind of hellish. And so it's not the goal for a person to try to control the experience while it's happening, because what we believe is that the more a person tries to exert control over the psychedelic experience, anybody who's tried to control their experience, period, at any point in their life, know that that's really associated more with anxiety. It's a struggle. It's hard to kind of control what you experience. That's counterproductive. And so when people are having a difficult experience, they may be taken to these difficult places, and there can be this increased risk for distress or symptoms afterwards. So things that I've seen in my private practice are things like increased anxiety, panic attacks, decreased mood, and a whole bunch of other kinds of reactions. And my hunch, again, this is a hypothesis here, is that this isn't just like people could easily jump to this being, oh, this is a drug side effect. There's something biochemically that is making certain people react. And there may be some truth to that, but I also think that there's a psychological element to it. So a person is kind of rapidly, when they take a psychedelic, dropped into their mind, if you will. And that might kind of sound esoteric, but anybody who's familiar with meditation, sometimes this is observed at 2-week silent meditation retreats where people are having reactivity or reactions. But the thing is that with meditation, it kind of takes time to get there. Like you got to spend the hours to potentially get to this place. But with a psychedelic, it's almost like a person is just dropped into what we call a non-ordinary state of consciousness, or this sort of dramatic shift in a person's relationship to their own mind. And they may not have the kind of skill or the traits, perhaps, to kind of engage with their own mind in that way. And so when the psychedelic experience isn't held in a supportive way, in a supportive environment, I think that this is where these negative consequences or negative outcomes. So here I'm referring to a particular kind of recreational use where it's perhaps spontaneous. A person has no idea about preparation or what might happen. They kind of decide to use a psychedelic on a lark. But again, not everybody, but for some people, this is what can happen. So I really want to emphasize here that this is more of the kind of non-clinical use. When we administer these compounds in a therapeutic clinical context, it's extremely rare that we would see these kind of adverse reactions.
Can you talk about the importance of training mental health clinicians through your organization Fluence in the best practices for psychedelic-assisted psychotherapy and psychedelic integration therapy?
My mind is right at the moment kind of flooded with all sorts of answers to that question because, when it comes to best practices, it's really hard to summarize because there are a lot of different elements to it. One thing that I'll say is that on one hand, I think many people who are trained in psychotherapy do have a skill set that is applicable. So it's not like a person has to get an entirely new profession to work with psychedelics. On the other hand, there can be a degree of unlearning that clinicians might have to do if they want to do this work. Particularly, I mentioned that kind of midwife aspect to it. Particularly, maybe putting some of the tools that we have in our toolbox that we use ordinarily down for a moment, or maybe not being so quick to use them in order to give the participants the space to be able to arrive at certain understandings or certain places, even emotionally themselves. If there's too much talking in the dosing sessions, I do think that it can interfere with the person's process. Now, there's also another extreme where people sometimes go to when they hear about this approach, which is like, oh, okay, all I have to do is sort of be a supportive presence, and that's it. Just like don't intervene and just be there. But that's not the case either, because there are times where I do think that these compounds can really elicit a certain kind of transference, countertransference relationship, or even kind of intensify the transference. This is just one example. So put plainly, it can affect how the patient or participant feels about their therapist. And there are different ways that things are magnified in the therapy that a person really needs to be trained in psychotherapy to kind of understand what is happening in the process so no harm is done or the benefits are maximized. So that's one piece of it, of a much larger picture. I know that it might sound very kind of inaccessible, but it's not. Like a lot of people already have the skills, and then there's just sort of maybe a fine tuning that people I think need to go through if they're going to do this work. But I want to kind of speak a little bit also to the sort of backdrop, which is that there's a lot of stigma that exists with these compounds. I mean, there's been misinformation about psychedelics and MDMA that's accumulated over the last 50 years. Maybe the best way to summarize that is with that now like often parodied commercial where, there's the holding an egg, and this is your brain, and they throw it against a frying pan and say, this is your brain on drugs. And so that attitude, although maybe sometimes comical to some, it really had an impact on the world. And one way that you see that is that psychedelics are not discussed in higher institutions of learning. Clinicians are not trained on how to work with people who are using psychedelics. 10% of the US population has had a psychedelic experience at some point in their life. And as a consequence, and I hear this from people who I work with for patients, they don't feel safe to talk about their experiences that they've had with psychedelics. And we know empirically, there's actual evidence, research evidence, that when healthy volunteers have been given a psychedelic, they identify it as one of the top 5 most important experiences of their life. So if things go well, I mean, that's something that we would hope would be invited into therapy. But alternatively, when people have these really scary, disorienting experiences, they might feel ashamed and not feel like that it's safe to talk to their therapist about some real distress that they're experiencing. What we're trying to do at Fluence, a company that I co-founded with my colleague, Dr. Elizabeth Nielsen, we're trying to correct this lack or gap in the education of professionals about psychedelics. And so we talk about their history, the current latest research, but we also, it's not just intellectual. We train clinicians in using concrete skills, how they can work with their clients who are maybe curious about psychedelics or have questions about them. And we do this by having weekend workshops. We offer reading groups. We offer mindfulness retreats, clinical consultation groups, and also free webinars. And we also have a diversity fund. And I think this is just really important to mention that we give scholarships to clinicians who come from underserved populations, so they can also have an impact in their own community.
And that's incredible. That's right in line with my mission of training mental health clinicians. But I wanted to say that it's not just training clinicians to perform the psychedelic treatment. That's done legally through a university study or a trial. But there's also this whole integration, because somebody may have done it in college but have not processed that experience. So there's this whole afterwards, both if you've done a trial and using that integration type of psychotherapy treatment, or if you've done it on your own and you need to process the experience. Am I correct in that?
Oh, absolutely. I'm so glad you mentioned that, because sometimes I forget to distinguish these two things, and it can be so easy to conflate the two. So just to sort of reiterate, usually when I say psychedelic assisted psychotherapy, What I actually strictly mean is being a therapist, doing preparation and integration, but also being there, being the therapist who actually gives the psychedelic to the participant in the case of studies. And this is only when we're talking about, say, MDMA or the classic hallucinogens for psychedelics, that's only legal right now in research studies. So this is definitely something I do not do this outside of clinical research. Again, this is a show about evidence-based therapy. I think that we need to really wait for these substances to be evaluated so we understand their risk-benefit profile before anybody is sort of illegally administering these substances. I think it would be definitely an ethical violation with your licensing board if you were a clinician doing this. Now, that being said, as you correctly said, psychedelic integration, there are people who are having psychedelic experiences outside in the world, whether it be going to South America for an ayahuasca journey or deciding to use a substance on their own or going to a party or working with an underground therapist. I mean, there's all sorts of, or ceremonial use. There are in some states legal provisions for people who can use certain psychedelics for religious purposes. So given that there are people using psychedelics in those contexts, I think as mental health professionals, we really need to be equipped to help and work with those people if that's something that they're seeking. And that does not require, nor at this time should it include, the administration of a psychedelic by us, by the clinician.
Thank you for clarifying that. What are some of the barriers that prevent the use of psychedelics as a treatment option for people with mental illness? And what can we do to overcome them?
Yeah, thank you for asking this. I want to kind of start on a positive note, which is I think we can overcome the barriers that exist. And now I'm going to go through the sort of litany of barriers. Well, so first, I mentioned the stigma that's accumulated for 50 years. So there's this stigma, this misinformation, and that can be addressed through education like we're doing at Fluence and also through research, right? Bringing evidence to bear. And I would be surprised that whether any kind of clinician receives more than an hour of conversation about psychedelics in their training. So the answer to that question is we just need to seek out education, generate more data, have people teach about psychedelics in these institutions of learning. And there's a great kind of humorous article that was published on Psychology Today. It was something like how to talk to your therapist about psychedelics. It's sort of very tongue-in-cheek. Again, you have to evaluate this for yourself as a client or patient, but perhaps even talk to your therapist about psychedelics or maybe encourage them to learn more. Again, I want to handle that very gently. Other barriers, one is funding. So as of really now, most of the research funding has come through donations, just through ordinary people to nonprofits. In the last year, we've seen the real rise of for-profit companies, but generally they're behind the nonprofits. And so more funding could be really helpful. And then another barrier would be accessibility to the treatment in the future. So if they are approved, so that's the big if, since these aren't take-home medications and really seem to require psychotherapy to accompany them, we're talking about like 8-hour psychotherapy sessions and then 12 90-minute sessions. And there's no billing code for 8-hour psychotherapy session. So there's all these institutional kind of barriers. And I think it would be really useful if insurance companies could help cover the treatment. This could be actually economically beneficial to insurance companies. So when it comes to treatment-resistant chronic PTSD, when you weigh the cost of the MDMA-assisted psychotherapy, the insurance company can recover the cost completely in 3 years. Mm-hmm. And we know that there's incredible healthcare utilization for people who are living with PTSD, emergency room visits, other kinds of ailments, not to mention the loss of productivity, but I'm just strictly speaking to the cost of the healthcare system. And this is not something that I've just sort of come up with. There's a paper that was published last year titled The Cost Effectiveness of MDMA-assisted Psychotherapy for the Treatment of Chronic Treatment-Resistant PTSD. So you can find this. I'll be honest, I'll just take the conclusions for granted because I'm not an economist and there's a lot of complicated math that I don't really understand. So I'll say that, right? For those of you who are listening who are kind of want to know the math behind that, you can find that paper. It's open access. You can read it. So there's a barrier in terms of this kind of insurance coverage because it's not a treatment yet. Question is whether it will be covered or not. And there's a good argument for having it covered by insurance. This research, specifically with MDMA for PTSD, wouldn't be possible without MAPS, which stands for the Multidisciplinary Association for Psychedelic Studies. You can visit them at maps.org. And other individuals like Tim Ferriss have really helped make this research possible. It wouldn't be possible without them.
Can you share a poignant example of where psychedelics had a major impact in someone's life?
Well, the first ones that kind of come to mind are the ones that I've witnessed directly on my own with my patients, or in case of this study's participants. And as much as I really would like to share them, I don't want to speak for those people. I also don't have their permission. But there is a participant who has spoken directly in the public about his experience. His name is Nicholas Blackston, and he's a former Marine, an Iraq War veteran, and also a participant in one of the MDMA-assisted psychotherapy trials. And you can find a video of him if you search on Google through the Horizons Conference, which is just, by the way, a psychedelic conference that happens annually in New York City. You can also read about his experience in this book called Acid Test. I'd actually really like to share a quote from Nick. The therapy, it saved my life. I regained the hope and purpose that I needed. The biggest thing was that I realized that I took a part of myself that I thought was evil and bad, the kind of Marine Corps side of me, did what it did in Iraq, and I pushed it down. And in my very first MDMA session, I had this vision where I went to myself, and it was this Marine Corps self, and it had red eyes and a demonic face and torn camis, and was just kind of chained to the wall. And I went forward and I opened the door and I said, I'm sorry for putting you here. And if you want to tear me apart, I understand. And the eyes went back to normal. And it's like we became one. It was something that occurred in my mind and was sort of like a vision, but I felt it all over. And I realized that I was cutting myself off from the rest of society. Like a puzzle piece, when you break off a chunk of it, there's no way it's going to fit to the other puzzle pieces. And I realized that I needed that part of myself.
That is incredible. And it sounds like he discovered this with himself, with probably the assistance of an excellent therapist, but this was insight that he came to through the experience.
Mm-hmm. It's not the same for everybody. So this is sort of, I want to say, like, some people have these kinds of experiences that are just, and this is the scientist coming out in me, right? Which is like, we don't know how this works.
Yes.
And, there are participants who have this kind of experience and it's transformational for them. But there are also participants who, for example, just have the experience of being able to think about their traumatic experiences or the losses of loved ones and not break down crying. And, there's nothing wrong with crying, but what I mean by that is not completely dissociate or disconnect or kind of become overwhelmed by where their mind goes. That's metaphorical, like about sort of encountering the monster within, but perhaps more just sort of coming into something that has been cut off for a long time or avoided. And for some people, that's what it looks like. Again, I don't want to take away from the beauty of this experience because it can be incredibly beautiful, but it's sort of like how I think it's really important that we also speak to the expectations of people that people have when they come seeking to get better from these substances, whether it be in clinical trials or in other contexts. We really want to hope for the best. And I do think that substances can be profoundly helpful. I think we also have to be really careful about the kind of expectations people have for how they're going to get better. And maybe I'll also just add that it's not like a flip of a switch. This quote makes it sound like that was it. If you read his story, his book, or if you talk to any of the participants from these studies, my shorthand for this is psychedelics don't make the change, but they make change easier. So it allows the person to, in various ways, be able to kind of make the changes that they want in their life, but it's not going to do it on your behalf. I mean, ultimately, it still just is a chemical that you're putting into your body.
And I think it's both the psychological and the physiological aspects of the medication. So it's going to be different for every person because every person has a different experience, has a different trauma. I'm not a doctor, but I think that MDMA allows for this physiological experience of being able to then look at whatever it is your experience is. Am I making any sense?
No, that's right. That makes right. That makes
so it's
sense,
going to be different. Yes. It's going to be different for every person depending on what's inside of them.
Right. That's right. And we don't know this for sure, but it's sort of like what's the content inside them. But also, this gets a little bit more into the realm of perhaps like personality disorders, but also like how a person is kind of constructed and how they're used to living, and so the more kind of process aspect of this work. And that's not, again, the evidence is we don't know. This is we don't know. So I'm not saying that this may or may not be helpful for people with certain personality disorders. I'm hopeful about that, but again, it's an unknown.
Yeah, and we'll just need to have more research. So from people like you. So what are you most excited about in mental health treatment today?
Well, I'd be lying if I said it was anything for me other than just the use of these compounds to support psychotherapy. That's my passion. What we see is that if you look from the late 2000s, there's maybe a few articles a year that came out on the topic. And now from the late 2000s onward, I don't know if I would qualify it as an explosion in research, but the trend is definitely upwards. And we're seeing maybe an article published every a week or every few weeks. Some of the questions that I think are fascinating is whether, but this is really getting ahead of myself a little bit, but is this going to become a treatment of last resort, or could this potentially become a frontline treatment? Because right now it's sort of like, well, again, this is the studies, chronic treatment-resistant PTSD. So nothing else worked. Psychotherapy alone didn't work. Pharmaceuticals didn't work alone. So let's try this. But could we potentially in the future say, well, why don't we, before we have somebody using a medication on a daily basis for a very long time, what if we tried this approach first? I think there's a good rationale potentially for that. Again, if the treatment is approved and shown to work. The other question that I think is really interesting for the future is how is it that these psychedelic assisted psychotherapies are working? If you want to be cost effectiveness right now is money needs to be put into evaluating whether these treatments are effective or efficacious or not. And once that is established, there's these really fascinating questions about psychological and biological mechanisms of action that are just kind of waiting to be explored.
If you had a magic wand and could improve one thing about mental health treatment today, what would it be?
I think my answer to this question, if I really had a magic wand, it would be granting greater access to mental health treatment generally for people who want it. So, we know that there are these disparities in mental health and also disparities in how people access mental health. And whether it be psychedelic assisted psychotherapy or any of the other therapies that you have on your podcast that you discuss, it's really all for nothing if people can't access the treatment when they need it.
I agree. So how can my audience learn more about your work, either online or in print?
First, if you're interested in learning more about MDMA and want to support that research, again, I would visit www.maps.org. If you're a person who wants to enroll in one of their studies, please go to MDMA-PTSD.org. Again, that's just the letters MDMA-PTSD.org. There, you can fill out a survey. This is national, so in the United States. So if there is a site nearby, it would connect you to the site if you're an appropriate fit. If you'd like to learn more about the training and education that my colleagues and I offer, you can find us, our company Fluence, at fluencetraining.com. And that's fluencetraining.com. And in print, I mentioned there's that one upcoming publication, halfway point of phase 3. Again, we're hoping for that to be available soon. Another paper that will be coming out soon is a piece that Elizabeth Nielsen and I created on the theoretical and kind of practical clinical framework for doing psychedelic harm reduction and integration therapy, which I spoke a little bit about, which we teach at Fluence. So we want there to kind of be a foundation people able to read and access about our approach. So yeah, keep an eye out for those two papers.
And all of that will be in the show notes. So, Dr. Gorman, on behalf of myself, my listeners, and all of the people that you've helped through your work, I want to thank you for your contributions to mental health treatment and for taking the time out of your busy schedule to help me and my audience better understand the use of MDMA for the treatment of PTSD.
You're very welcome. It was a pleasure to be here. Love to come back again.
I would love to have you. So be sure to check out my website, therapyshow.com, which has many resources about mental health. There you will also find how to submit questions, stories, or insights that you have about the mental health system, or suggestions about who else I can interview and how I can improve the show. I'd like to close by reminding our listeners to please subscribe, share, and review this podcast so that you, someone you love, and people around the world can gain more benefit from therapy. There is no need to suffer in silence. Get the help that you need to create the life that you want.